Bronchial asthma is a slide seen. So bronchial asthma is a inflammatory airway disease, which nowadays people are wanting air all the time, and because of many inflammatory disorders which are happening in our lungs, in our lung tissues, and our bronchioles, then we get this. Okay, so I've put up this case scenario where there is a 30-year-old woman with complaints of episodic breathlessness, often following exertion, waking up at night with breathlessness. Okay, so there's a woman like this, and then when you go into the past history, there is a history of smoking and tobacco chewing, and at the moment the patient has also developed sore throat and fever. Okay, so when you look at this case scenario, who knows, this kind of problem-based question may also come in the form of a question for your final exam. So I've just put up this case scenario. Can anyone tell me exactly if there is episodic breathlessness, okay, especially with exertion, can we classify this as an asthmatic patient? What is your view? So could this be classified as a as a case of bronchial asthma? Okay, yes. So patients often come with breathlessness. Patient always come with the complaint of breathlessness and usually following exertion. So the objectives of today's class is to describe the clinical presentation of asthma, and then the related pathophysiology. Will go into it a little bit. And then what exactly we have to do when a patient comes with asthma, where do we have to state the principles, okay? Most importantly, at your level, you have to classify drugs according to their mechanism of action. This is very, very important. As you've seen in the last semester exam, most of the questions have come in relation to mechanism of action or adverse effects. Okay, so please be ready to, when you read pharmacology, please read in those lines. And then we have to outline a pharmacotherapy for the different stages of asthma. Okay, so based on these objectives, let's straight away go to what exactly is bronchial asthma. So by definition, bronchial asthma is a chronic respiratory condition. Look at these triads, okay? Characterized by hyperresponsiveness of tracheobronchial smooth muscle to a variety of stimuli. Variety, that means this whole bronchial tree, starting from this big two branches here, both the lungs, the bronchioles of the lungs, are in a state of hyperresponsiveness. That means there are some stimuli which will make these bronchioles hyper-responsive. Okay? So what exactly do we mean by these stimuli? Number one, tobacco smoke. If you remember the case scenario, I've also given a past history. The patient had given a history of, tobacco smoke. Infections, cold, the common cold, the flu, which we are all, scared of now, and pneumonia. Allergens, could be allergic to food, could be allergic to pollen or moles. Nowadays, everyone is scared of moles also. Dust mites and pet dander. Then you have air pollution. Then you have some toxins which may produce stimuli or trigger hyperresponsiveness. Then extreme changes in temperature. We all know about this. Winter, summer, some of us do suffer from hyperresponsiveness of the lungs. Now, notably, some in the viva, some of you may be asked, what are some drugs which can stimulate hyperresponsiveness to bronchial asthma or to the bronchioles? Like aspirin, other NSAIDs, and beta blockers. If you remember properly, when I was talking about beta blockers, I said the non-specific blockers, beta blockers, are contraindicated in a patient suffering from bronchial asthma. We all know, if we go back to the receptors of adrenergic receptors. You have the beta 1, beta 2, and beta 2 especially present in the bronchial smooth muscles and also the uterine smooth muscles. Some food additives also which are added to our food may trigger hyperresponsiveness, and we have also done this acid reflux, GERD or GERD we say. That also is one of the predisposing factor to produce bronchial asthma. So kindly remember these stimuli which can cause bronchial asthma. Because of all these stimuli, we say there is a hyperresponsiveness of the tracheobronchial tree. If you look properly, normally this is what you see. But if there is a hyperresponsiveness, there is narrowing of these air tubes. Now let's go to see how this narrowing of the air tubes happen. When there is hyperresponsiveness, be it any stimuli, be it any trigger, it can cause increased secretion, mucosal edema, and mucus plugging. And all these increased secretion or edema or a mucus plug, okay, which can happen, it is because there is inflammatory reaction. There is an inflammation, okay. As such, a normal airway which is, very smooth, very nice, then it so happened that it is inflamed, that it is swollen, and then it goes out and cause edema. And then there's so much of mucosal secretion. Okay, pathophysiology, which I'm showing you here, inflamed, swollen, bronchial mucosa with all these secretions. Then there is muscle spasm. Okay, so when you look at this, clinically the patient will show you, like I showed you just now, shortness of breath. And when you auscultate, then you will find an additional sound like the wheezing and the cough which is persistent. And then later on in the long run or chronic cases, they always present with limitation of activity. And what we have to remember, which I'm showing you here nicely, a life-threatening condition known as status asthmaticus. Status asthmaticus. So how does that inflammation occur? This pathophysiology, please understand nicely. Immediately when there is a stimuli, when there is triggering factor, then the first inflammatory mediators are histamine, the enzymes like the protease, or the TNF-alpha, tumor necrosis alpha. Then after some hours, okay, then the cell membrane is activated. If the cell membrane is activated, you get the release of mediators like the prostaglandins, which are very, very powerful, and the leukotrienes and the platelet activating factor. Still then, if it is not controlled the cell membrane, then it goes on to the genes. If there is gene activation, then gone case, because cytokines will be activated like the interleukins and the tumor necrosis alpha. Okay, so we have the histamine, we have the enzymes, we have the prostaglandins, we have the leukotrienes, the platelet activating factor, the interleukins. All these will cause increased mucosal secretion, it will cause a plaque, and ultimately there will be bronchial constriction. This is what is happening. See? And chronic obstructive pulmonary diseases will be done on Wednesday. Okay, so nicely you're seeing an airway which is very nice here, but if there is inflammatory reaction, then the airway, increased mucosal secretion, there is mucosal edema, and ultimately what happened to the airway? It becomes bronchoconstricted. This is called bronchoconstriction. So if we understand the pathophysiology nicely, where the airway, the diameter is less than 2 millimeter in diameter, then definitely the patient is suffering from bronchial asthma and coming with breathlessness, especially on exertion. And the life-threatening condition of this is status asthmaticus. So the principles of treatment is like this. You will give drugs to relieve bronchospasm. That means you will increase the airway, which should be more than 2 millimeter. And you will try to give drugs to reduce the bronchial inflammation. And if a patient, is already having a chronic inflammation, you will give drugs to prevent repeated attacks. Again, I'm repeating, the principles of treatment are to relieve bronchospasm, to reduce bronchial inflammation, and to prevent repeated attacks. So the drugs, if you want to control asthma, this is, in the rehabilitation area. You want to control the environment, no smoking, no pollution. Then you can give drug therapy, treatment of comorbidities in case the patient is suffering like diabetes or others. Then physiotherapy is a must, and patient education is important. Okay, so these are the principles of treatment for a patient suffering from bronchial asthma. Then the drugs are like this. Please note down all these drugs. Exactly, I've taken from K.D. Tripathi. Bronchodilators. Now the question may arise, name some bronchodilators. So the first bronchodilator is your beta-2 symptomimetic, okay, like salbutamol, salmeterol, formoterol. These are other drugs, newer drugs which have come up nowadays like remiterol, bitalterol, and terbutaline. Another bronchodilator is your methylxanthines, like aminophylline. Then you have anticholinergic drugs like ipratropium bromide and tiotropium bromide. Apart from theophylline, these other drugs we have come across all the time. This one when we were doing cholinergic system, this one when we were doing adrenergic system. So name some bronchodilators, name some from adrenergic system, name some from cholinergic system, and then you add aminophylline, which is a methylxanthine. Okay. Now the next group of drugs are the stabilizers to the cells, like the sodium cromoglycate and ketotifen. Then you have the LT antagonists, leukotriene antagonists, like I told you, by 5 to 6 hours, sometimes 12 hours, there will be mediators like the leukotrienes. So you inhibit the leukotrienes by giving montelukast and zafirlukast. Then you give corticosteroids. Corticosteroids, they are the main anti-inflammatory drugs. Here you can give hydrocortisone and prednisolone, beclomethasone dipropionate, budesonide, okay, which is given as an inhaler. And then you have an anti-IgE antibody, omalizumab. So again, I'm just showing the slide. You have the bronchodilators. You have adrenergic system, the beta-2 stimulants. Then you have the cholinergic, anticholinergics, ipratropium bromide. Then you have theophylline. Okay. Then you have mast cell stabilizers, sodium cromoglycate, ketotifen. Leukotriene antagonists like montelukast and zafirlukast. Then you have corticosteroids. You can give both as inhalers as well as systemic drugs. Then you have the anti-IgE antibody omalizumab. First we come to the mechanism of action of beta-2 sympathomimetics or beta-2 adrenergic drugs or beta-2 agonists. I'm not talking about antagonists, I'm talking about agonists. That means they will stimulate beta-2. They will stimulate beta-2. I'm repeating this. They will stimulate beta-2, which is present where? In the bronchial smooth muscles. Okay? Now, we have mentioned salbutamol, salmeterol, formoterol, roniterol, but we have not mentioned adrenaline. Adrenaline is such a powerful adrenergic drug. Why we cannot give? And the answer is, it is not a specific beta-2 agonist because it can also stimulate beta-1, which is present in the heart. And you don't want stimulation of beta-1, which is present in the heart, or the alpha, which is present in the bronchioles, in the vascular smooth muscle, because it may cause palpitation, it may cause increase in blood pressure. Again, I'm repeating why adrenaline, why isoprenaline cannot be used, because they are non-specific receptor agonists. They can stimulate beta-1, they can stimulate alpha-1, which is not required because it may cause adverse effects like palpitation. Beta-2 sympathomimetics, we are taking beta-2 specifics like salbutamol and salmeterol. Okay, so they are the fastest acting bronchodilators, especially when you are inhaling them. When you give within 5 minutes, they will cause action and last 2 to 4 hours. Now, what exactly happens if you are stimulating the beta-2 receptors? If you're stimulating the beta-2 receptors, then you're activating adenylate cyclase and cyclic AMP and decrease the release of calcium. In the endoplasmic reticulum, there is decreased release of calcium, and therefore it will lead to smooth muscle relaxation. That's why that very big word like bronchodilation we are saying. Okay? And then apart from adenylate cyclase activation, it can also help in the inhibition of mediator release. So there will be no release of histamine, no release of prostaglandins, and no release of leukotrienes. Okay? So nicely these mechanism of action. Please go through once again after the class. The clinical benefits, again I'm repeating, bronchodilation without tachycardia because you don't have beta-1 stimulation, unlike which drug? Adrenaline. It can cause inhibition for the release of chemical mediators. That means it stabilizes mast cell. Because it doesn't cause release of chemical mediators, there will be no mucosal edema. So the microvascular permeability on the whole will be decreased. At the same time, it can also cause restoration of mucociliary transport mechanism in the respiratory tract, resulting in reduction in secretion. So it will inhibit secretion, inflammatory mediator secretion, it will inhibit edema, it will also inhibit microvascular permeability. Apart from what action? Apart from bronchodilation action. Adverse effects are like this. Because they also work in the smooth muscles, in the skeletal muscles, they can also cause number one adverse effect. So for a person taking asthalin syrup, okay, containing salbutamol, they will always complain of muscle tremor. Sometimes they may complain of restlessness, sometimes because of, somehow or the other beta-1 is being stimulated, it can cause palpitation. Then sometimes it may cause hypoxia, hyperglycemia. Apart from this, these are the minor adverse reactions. But most of the time, patient complain of muscle tremor, patient complain of restlessness, palpitation and nervousness. Apart from salbutamol, we have another long-acting salmeterol, long-acting beta-2 agonist known as salmeterol. Then you also have formoterol. Okay, so salmeterol, formoterol, then you have salbutamol. The next bronchodilator, which is very important, is your aminophylline. You see this? Coffee. You see here tea, coffee, tea, coffee, tea. Then you have the methylxanthins. You have the methylxanthins. If I don't admit, you will lose your attendance. If I admit, the flow of the talk is gone. Now, there are three naturally occurring methylxanthins we have seen all. You have the caffeine, you have the theophylline and the theobromine. Okay, theophylline have been marketed. Okay, as such, theophylline is marketed. But then, the most common marketed drug is the aminophylline. Aminophylline. Then, this is a combination of theophylline and ethylene diamine. So when you talk about bronchial asthma in the olden days, you're talking about theophylline. Everybody is talking about that because that is the main drug in the treatment of bronchial asthma before, salbutamol came out. You look at this diagram, bronchodilation, either you do something to cyclic AMP, then you won't allow the, accumulation of calcium, or you will go to inhibition of phosphodiesterase. This is PDE, phosphodiesterase. So that there will be no degradation of cyclic AMP. I'm showing you here. There will be no degradation of cyclic AMP and then you get more of this AMP. Okay. So theophylline, beta-2 agonists, they mainly work to adenylate cyclase, that is beta 2. Whereas theophylline works towards an inhibition of one enzyme known as phosphodiesterase enzyme. Okay. In the CNS, it may cause stimulation. Because I'm showing you this pharmacological action in the CNS, it may cause stimulation. CVS, it can cause stimulation. Because of this, it is absorbed so nicely, it crosses the placenta, secreted in the milk. All these things are there. Why I'm showing you the pharmacological actions so nicely? Because they are drugs which are very, very low therapeutic index. Very low therapeutic index. So, if the therapeutic range is between 0.2 to 2 milligram of the serum, of the plasma. If you go beyond this, beyond 2 milligram, then there will be stimulation of the CNS, there will be stimulation of the CVS, and it will go into adverse drug reaction. If you go lower than 0.2, then there will be no pharmacological action. So the index, the range is so less. That's why this is a drug which has to undergo therapeutic drug monitoring. Okay? So that's why it's shown here. Higher than 4 milligram may cause arrhythmia, convulsion and coma. Again, higher than that may cause insomnia, headache and nervousness. I don't know. Most of you, those who take, around 10, 15 cups of coffee per day, do you feel active or do you get headache? And when you come next day in the class, you get palpitations. Some of you say, oh, I want to, go to the restroom because there is so much of vomiting. And then some of you may come with tachycardia. There is nothing. It is because the methyl xanthines in the form of hydrobromate, okay, theobromine, or your caffeine which you are taking, it has gone higher than 4 milligram and started stimulating the CNS, started stimulating the cardiovascular system. Okay, so this is a very, very common adverse drug reaction which you come across with a drug aminophylline or theophylline, or when you're taking too much coffee. Okay, so the preparations are like this. You can get theophylline, you can get aminophylline, you can get dry hydroxyethyl theophylline also, what we call as derifylline. This is very important. But I don't want you to write during exam derifylline. Now we have come to a very good bronchodilator, that is anticholinergics. Anticholinergics, we don't give atropine because again atropine is non-specific. Okay, that's why we give drugs like ipratropium bromide and tiotropium bromide. Okay, what exactly these drugs do? Now, if you look at the airways, they are innervated by a supply of efferent cholinergic parasympathetic autonomic nervous system. Now, if there is mainly activation of cholinergic system, there is release of acetylcholine resulting in stimulation of muscarinic receptors. Now, stimulation of muscarinic receptors will cause airway smooth muscle contraction and release of secretion from the submucosal airway glands. Okay, so this is the role of acetylcholine. It works through these receptors like M1, M2 and M3. But M3 are mostly important in the smooth muscle larger airways. And muscarinic receptor activation of these M3 receptors will lead to contraction of airway smooth muscle and cause bronchoconstriction. So, again I am repeating, M1 is present, M2 is present, all related to acetylcholine. But here in the bronchial smooth muscle, we want to remember M3. Because if there is stimulation of M3, it will lead to contraction of airway smooth muscle and cause bronchoconstriction. That's why you give anti-M3, and those anti-M3 are known as anticholinergics. And we are not taking atropine, mind you. We are taking specific M3 antagonists, okay, or blockers like ipratropium bromide and thiotropium bromide. I hope this is understood. Next, we have finished with the bronchodilators. Again, I'm repeating. You have adrenergic agonist bronchodilators. You have anticholinergics, okay, and then you have theophylline. The mechanism of action are all different. I have just given you just now. Okay, now we come to another group of drugs known as the mast cell stabilizers, like the Cromolyn sodium, or very simply known as the sodium Cromoglycate. Now, what happens to this compound? We say it is a stabilizer of the mast cell. That means it inhibits degranulation of mast cell. It does not allow the bursting or the opening up of the mast cell, so that whatever is present inside the mast cell, whatever inflammatory cells or mediator release action is there inside the mast cell, is being inhibited. And how is this done? It is done by prevention of chemotaxis of eosinophils and neutrophils. Local inflammation is prevented. And the molecular mechanism is that it works together with the chloride channels. It delays the chloride channel so that there will be no hypopolarization, there will be no relaxation, there will be no opening up of the mast cells. So, molecular action is delayed chloride channel opening. It stabilizes the mast cell how? By inhibiting the degranulation so that inflammatory cells and mediator release does not happen. Chemotaxis of eosinophils, attraction of eosinophils and neutrophils will not take place. And this particular drug is given as a metered dose inhaler. At the dose of 1 milligram per dose, you can give as a puff. Now, this drug is not a bronchodilator. It cannot be given, to treat bronchial asthma. That's why what is written here? It is given as prophylaxis in asthmatic condition, or when there is an allergic rhinitis or allergic conjunctivitis. I hope you remember this drug. Sometimes it comes as a short note. Then leukotriene antagonists, you understand that because they inhibit or they block cysteine leukotrienes, these are the receptors, so they will not allow the activation of LTB4, LTD4 or LTE4. That means the whole leukotriene tree is being inhibited. And because of that, it also is partially called a bronchodilator, and it doesn't allow eosinophil count and inflammatory mediators like the leukotrienes LTB4, LTD4 and LTE4 to come out. Okay? It is not a purely bronchodilator. That's why for the real treatment of bronchial asthma, this is not kept. But it can be given in mild to moderate asthma, especially in children. See these drugs like montelukast, zafirlukast. Next, I come to an important anti-inflammatory drug, that is corticosteroids. The question will come to you is, why we are not giving NSAIDs? Because NSAIDs themselves are stimulus or triggering factors to produce bronchial asthma. How this is done? I think when we were doing prostaglandins, it must have been taught to you that if you inhibit prostaglandins, who will take the upper hand? Prostaglandins. When you're inhibiting prostaglandin, the other side is you're allowing more activation of the leukotrienes. That's why aspirin is not given, diclofenac is not given, but we give corticosteroids, because corticosteroids will inhibit all the cardinal signs of inflammation. It will suppress inflammatory response to all noxious stimuli. That's why it's such a nice drug. It is called the best anti-inflammatory drug. It will not allow, mediators like cytokines, TNF, PAF or prostaglandins, which will be activated during bronchial asthma. Now I'm feeling really bad. Why my talk today is making people sleepy. Now you have inhalers like corticosteroids inhalers. I've given star mark because this comes. The question is, write briefly on inhaled corticosteroids used in bronchial asthma. Now mind you, corticosteroids are not bronchodilators. They are anti-inflammatory drugs. They reduces airway inflammation. That's why they are called anti-inflammatory. They've got anti-inflammatory action. Now, if you're talking about an inhaled corticosteroids, you cannot mention all the corticosteroids because only some are used, like as inhalers, like beclomethasone, budesonide, fluticasone, and triamcinolone. Beclomethasone, budesonide, fluticasone, and triamcinolone. But in the long run, if you are giving too much of steroids, corticosteroids, then adverse effects are like mood changes, osteoporosis, growth retardation, and adrenal crisis. Okay, so we'll learn more about corticosteroids when we are doing corticosteroids itself. Okay. The last drug is omalizumab. This is anti-IgE antibody, anti-IgE inhibitor. That means it inhibits IgE production. So it neutralizes free IgE in circulation, but it's very expensive. It's reserved only for resistant cases. It's a monoclonal antibody. Monoclonal antibody. So the treatment of asthma is like this. Step 1, you start with bronchodilators like salbutamol, terbutaline, be it orally or inhaler. Step 2, you can start alternatively between giving salbutamol, terbutaline, and Cromoglycate. It's a mast cell. Step 3, you can start giving also leukotriene inhibitors like Zafirlukos, Montelukos, and also steroids. Because the patient will come with, every now and then suffering from bronchial asthma, so you will add steroids, okay, as inhalers. Next, you will also add steroids together with beta-2 agonists, preferably long-acting like salmeterol. So these step 1, step 2, step 3, step 4, different books are giving different ways of doing treating bronchial asthma. You can have a look. This is the shortest way which I am giving you. So at your level, if you remember this much, it's more than enough. Most importantly, when a patient is coming with repeated attacks of breathlessness, almost where the patient comes with unconsciousness in a state of, hypoxia. This situation is known as status asthmaticus. What we are seeing now, coronavirus or COVID-19 is causing almost all patients to go into status asthmaticus. So, very important for you to remember, in such a state, you always have to give hydrocortisone hemisuccinate. This is a corticosteroid. You give 100 milligrams stat IV, followed by 100 to 200 milligram 4 to 8 hourly infusion. You will give a nebulizer salbutamol. Oxygen is a must. Okay, humidified oxygen is a must. Apart from that, to control the inflammation, you have to give hydrocortisone, hemisuccinate number 1, then you will give a powerful bronchodilator, salbutamol plus ipratropium bromide. You cannot add this just like that. You will have to give with intermittent inhalations with oxygen and nebulization. Later on, when the patient has stabilized to some extent, then you can give salbutamol or terbutaline by other routes apart from nebulized inhalation by intramuscular or subcutaneous route. If this does not work at all, then definitely you have to intubate and give mechanical ventilation. Well, like you have seen everywhere in the world, especially in India, all these things. Now, if there, usually this is a predisposing factor is always infection. So you have to give antibiotics. Antivirals are being given now together with antibacterials. And hydration of the patient is number 1, humidified oxygen together with nebulized salbutamol, ipratropium, and IV saline for, the patient should not be dehydrated. And if there is acidosis, then you give sodium bicarb. please go through. I'll be uploading these PowerPoints again, okay, today. So please go through the how you will manage status asthmaticus, and it's important nowadays. Okay. I just want to go through again about a metered dose inhaler, okay, metered dose inhaler, where it gives a short burst of aerosolized medicine, a rotahaler, which we have seen there, and a spacer, which you have not seen, okay, but a rotahaler you have seen, metered dose inhaler you have seen in the practical class. So this is how you give to all your patients. This is how you teach them. Take a deep breath, hold your breath, give a puff, okay. These are all which have been taught in the practical classes. Something about aerosols. When you're giving an inhaler, it is the aim is to deliver to the alveoli without settling in bigger tubes. That means it has to go to the smaller alveolus. The particle size of the drugs should be should be more than 10 micron. They are deposited more in the mouth and oropharynx, but it should be less than 0.5 so that they will go directly to the alveoli. This is a very important PG question which has come nowadays. The particle size in aerosols, less than 0.5 micron. Okay, so aerosols can be given in solution like a metered dose inhaler or nebulizer, or it can be given in a dry powder like rotahaler and spinhaler. I hope you have understood important things about bronchial asthma. So the questions which can be asked to you is, classify drugs used in asthma according to mechanism of action, meaning whether they are bronchodilators, anti-inflammatory, or anti-leukotrienes, or mast cell stabilizers, or simply monoclonal antibodies. So you please remember these. You cannot say ma'am didn't teach all this. Then sometimes inhaled steroids are asked. I have given you that particular slide. Adverse drug reaction of aminophylline is important to remember. I didn't write here. Salbutamol adverse drug reaction also is important. Sodium Cromoglycate, I've given here. So because aminophylline, I've written number 1 adverse drug reaction because it has got a narrow therapeutic index. Pharmacotherapy of different stages of asthma, 1, 2, 3, 4 steps I've given you. And most importantly is the management of status asthmaticus. And the main mechanism of mast cell stabilizer sodium Cromoglycate is what? It delays the chloride channel and does not allow hypopolarization, so that the mast cell does not degranulate. Okay? Then you have very good anti-inflammatory drugs like corticosteroids, where you can give both as inhalers as well as systemic oral drugs. Then you have leukotriene antagonists, zafirlukos and montelukos. Apart from this, please don't forget to remember omalizumab with its monoclonal antibody. Please do not forget again and again, I'm telling you, don't forget to remember how to treat status asthmaticus. If you go back to bronchodilators, please remember salbutamol is a beta-2 agonist. Methylxanthins, that is theophylline, they are phosphodiesterase inhibitors. That means they will not allow the degradation of cyclic AMP. Beta-2 agonists, they work on beta-2 receptors to increase cyclic AMP. In another way, aminophylline will inhibit the degradation of cyclic AMP by inhibiting what enzyme? Phosphodiesterase. Then you also have an anti-M3, that is anticholinergic to M3 receptor, that is your ipratropium bromide and tiotropium bromide. I hope you will once again, at any particular time today that you have, just go through the slides which I'm going to upload now. Okay? Thank you everyone.